Good evening, consultants, teachers, and colleagues on the call. You're welcome to today's meeting. We start with a presentation on cardiac pacing. And Prof, please, your audience.
Okay. So I guess this is just going to be a brief review on pacemaker, basics of pacemakers, just to deal with the modes of pacemaker. And as the highly professional forum, we already understand the necessity for pacemaker, the purpose for why we do it. Um, we also know the technical know-how of how it's implanted. So, but I think our focus or the benefit of this room will just be to see when we discuss about pacemaker modes and how we can adjust the programming. So I think that will be the focus of this session. So even there will be many slides that we've gone through before that will not actually really bother ourselves or focus on. But our focus will be to look at the pacemaker modes, how we can recognize the modes, and how we can troubleshoot some issues when the pacemaker is not functioning optimally. So, brief preamble is that we all know the purpose of why we do a pacemaker because we have some conducting fibers in the heart that's meant to generate the necessary action potential for electrical conduction. And this electrical conduction would culminate in a mechanical activity of the heart. So we all know the locations of the specific conducting fibers, which include the SA nodes, the AV nodes, the east bundle, its branches, that's the left and right bundle, and the Purkinje fibers. So we won't waste our time on history, and this will not come out in the exams. Okay, but it was first discovered in 1932, and the first external pacemaker was done in 1950. If the first external pacemaker looked like moving a generator, so it was very difficult to make clinically visible at that time. So the first pacemaker that was implantable um, was done by Medtronic, and from there have been progress in the modification of a pacemaker. This modification had gone from very big size that was implanted in the abdomen to bullet size that can just be dropped in the ventricles. So which we call the leadless pacemaker. Uh, we all know that the need for pacemaker is increasing since there's more awareness, and we should also know that apart from pacemakers, we also have other implantable devices, which we're all aware of, ICDs and CRTs. So I'll just skip many slides so as to save time, so we can ask questions and modify information. So indications, pacemakers, we all know that pacemakers are for bradyarrhythmias, either from SA node bradyarrhythmia or AV node bradyarrhythmias. So one important part is that it can be used in sick sinus syndrome, where patient has a tachybrady syndrome. So the tachy part you treat medically with medications, beta blockers, basically. The brady symptoms of it will be treated with a pacemaker. Okay. And we also know that SA nodal block can happen, either an exit block, SA nodal arrest. So all those would need a pacemaker for functioning. So this is the tachybrady syndrome in patients that have sick sinus syndrome that we discussed. So in AV nodal disease, pacemakers are actually indicated when the patient moves from second degree, or in second degree AV block, high grade AV block, or complete heart block. So when we start time with what we know about the different types of second degree AV blocks, we all know the different ECG features of the AV blocks. Okay, so pacemakers will be indicated when it's second degree Mobis type 2, an high grade AV block, or incomplete heart block. So we all know pacemakers can be as temporary or as a permanent pacemakers. We also know that, please, if I'm too fast, let me know. And if I'm not audible, also let me know.
Yes, Prof.
As I said, the modification of pacemakers moved from very big batteries to bullet-sized batteries. One important thing we should know that for the pacemakers, the common pacemakers would have the can, that's the battery, the header. That's usually the latest ones they make. So the battery, the header, that has the two ports to fixing the electrodes, and we have the leads, which are also called the electrodes. So each of the electrodes, um, there's unipolar and there's bipolar electrodes. So they don't usually make unipolars anymore. They've advanced to bipolar. So bipolar means you have the positive and negative charge at the tip and at the ring. So between the ring around this black portion to the tip, you will have the two electrical charges. So the tip will be negative charge, the ring is positively charged. So as to complete the circuit for electrical activity to happen. We all know that electrical current will move in a circuit which has the positive and the cation and anion end. So the positive and negative charge ends. For the unipolar, in those days, the unipolar, so the tip happens to be of the lead is the negatively charged, meaning that it has only one electrode inside, while the body or the can is the positively charged. So it's going to use the tissue of the body and the fluid system as the conduction to conduct the electricity. So the can becomes the positive end, the tip of the electrode is the negative end. So that is how unipolar works. So, but then the benefit of unipolar over bipolar in those days is that unipolar electrodes were slimmer previously than the bipolar electrode, but with modernization of the electrodes, they are both as slim as possible. Then unipolar electrodes previously then could easily fit through the venous tissue when the procedure is done through the veins, so either the axillary vein or the subclavian vein. So when you do the puncture, you're passing a sheet there. So the electrodes will have to pass through that sheet. So if the electrodes are too big, in those days, the bipolars were very big. So it was difficult for it to slide through the sheets. So you need a bigger sheet like 9 French, 10 French, big size sheets to put into the femoral vein, through the subclavian vein or axillary vein. And that usually makes it difficult for the electrode to slide through it or to get a good venous access. So, and then the electrodes can easily fracture because your puncture is around the first rib and the clavicle. So when the patient struggles their shoulder, they can easily fracture the electrodes. So that was why they were using the unipolar slimmer electrodes then. But now, as I said, in modernization, the electrodes are now as slim. Bipolar electrodes are now as slim as unipolar electrodes. And they have better coating, and this coating allows reduces friction between the clavicle and the first rib so as to reduce fracture around the electrodes. So another modification that has been done is coating the tip of the electrodes with steroids. So if it lacked in the early stages, um, so in the early stages, the tip of the electrodes did not have drug coating. So what happens then is that fibrosis form very fast, and fibrosis forming very fast reduces the threshold significantly. We all know the meaning of threshold. Um, Threshold simply means the minimum energy required, the minimum voltage required to generate an action potential or to capture the myocardium. So in those days, when the electrodes were without drug coating, um, moment you screw into the myocardium, fibrosis will form very fast. Fibrosis forming very fast. Remember, a fibrotic tissue is different from the normal myocyte or myocardium. So the electrodes, the threshold drops, and so the battery will have to discharge at higher voltages so as to capture myocardium for action potential. And so the higher the voltage you use, the more you consume the battery. So that usually drains the battery faster. So that's now brought the fact of putting drug coating around the tips of the electrodes. So they call them drug coated leads. So steroids are actually put in there. So the purpose is to reduce inflammation when you screw in the electrodes and reduce inflammation around the myocardium. And the moment inflammation is reduced, then that means that you can still maintain your threshold at which you started with, because fibrosis is not formed very fast. And so that helps the electrode to merge well to the myocardium, delay fibrous tissue formation. And by the time fibrous tissue are formed, it usually takes like 6 weeks. And 6 weeks, yeah, 4 weeks, 4 to 6 weeks for proper fibrosis to form. Then the fibrotic tissue will not be as hard as when you were not using drug coating around the tip of the electrodes. So it has been favored that each of the tips of the electrodes should have drug coating so as to prevent early formation of fibrosis and increasing voltages of the myocardium, which can drain the battery faster. Okay, so now going to the types of leads that we made. So we have two basic types of leads. We've already discussed unipolar and bipolar. So there's one time important information we should let you know, that when you use the word unipolar and bipolar, it means that there are two cables, two wires inside the sheet, inside the lead. I mean, so two wires are inside. So one will be positive charge, the second will be negative charge for bipolar. But for unipolar, it's just one wire inside the lead. Okay. Now, so the types of leads that we have the screw leads, meaning that at the tip of it, you see something like a corkscrew where it can screw into the myocardium. And we have the tine leads that looks like a hook. So tine leads. So the tine leads are called passive leads, while the screwed leads, the leads that you have to, that has a screw at the tip, are called active leads. Now, also one important information we should have here is that moment you can see this, if my arrow is showing, this metallic region. The metallic region confirms to you that this person is going to have a ring electrode and the tip electrode. So telling you there's bipolar. So ring electrode will be the positively charged. The tip electrode would be negatively charged. Okay. So as we previously described, we have the unipolar and bipolar. We said unipolar, the tip of the electrode is negatively charged, while the body and the pacemaker battery will be the positively charged end. So for unipolar, we said both charges are the electrode, are the ring part of the electrode, which we showed previously, positively charged, and the tip of the electrode, which is negatively charged. That both ends are in the heart and screwed to the myocardium. Okay, so as just further buttressing what we said, unipolar, the tip is negatively charged, the can is positively charged. For bipolar, the ring is positively charged, the tip is negatively charged. Okay, so this is a nice chest x-ray of what you want when you're doing a dual chamber pacemaker. So meaning that one electrode is in the atrium, right atrium, the second electrode is in the right ventricle. So every time we do an X-ray, it's always important you do PA view and the lateral view. So the lateral view, you just want to see the separation that the atrial lead is in the appendage. This is how we all know that the right atrial appendage is anterior, right, to the atrium. So the electrode should be sitting anteriorly in the appendage. While the lateral view here, you want to be sure the ventricular electrode is not facing the diaphragm so as not to perforate into the diaphragm. You just don't want it facing the diaphragm, number one. And number two is you want it to be looking at the septum as much as possible. You don't want to pace at the apex. You want it to be looking at the septum. So, as I said, just avoid pacing the apex as much as possible. So why? We don't want to pace the apex because we don't, when you do apical pacing for the right ventricle, it has reports or studies have shown that it causes, it worsens the ejection fraction. It's worsen the synchrony between both ventricles, and at long term, it causes heart failure with reduced ejection fraction. So it reduces their ejection fraction at the long run. You don't want to pace around, you don't want to the electrode to be facing the diaphragm, because I said you don't want to perforate into the diaphragm, and you don't want the patient to be having hiccups at each time they are pacing, because we all know diaphragm pacing will cause hiccups. Another thing that can cause hiccups for the patients would be that if this atrial lead perforates the appendage, just remember appendage is a very, the wall of the appendage is very thin, so it's very easy to perforate it. So you don't want the electrode to perforate the appendage because the phrenic nerve runs just on top of the appendage. So if you perforate it, then you'll be stimulating the phrenic nerve and the patient will be having hiccups. Okay, so they can both, so both atrial lead and ventricular lead can cause diaphragmatic stimulation. That is actually an MCQ question. The ventricular lead can cause diaphragmatic stimulation because you can perforate into the diaphragm. Atrial lead can cause diaphragmatic stimulation by stimulating the phrenic nerve. Okay. So we go to the pacemaker mode, which I think is majorly our area of interest. So for the pacemaker mode, we all know they have the coding, the unified coding system. So unified coding system is actually between the North Americans and the British coding system. So the purpose of that coding system is to have it universal, meaning that either you are implanting a pacemaker in Japan and someone else had a pacemaker implanted in US, if we have a universal coding system or unified coding system, it will be easy to follow through rather than looking for individualized coding system per country. We won't say that, oh, the coding system in US is this way, or the coding system in India is this way. No. If it is unified, then we all have an acceptable way of managing the patients effectively. Okay, so with this agreed unified coding system, we have 5 parameters that are being checked out for the coding system. So that defines the pacemaker mode. So um, it's alphabetically arranged, and also it is categorized in Roman numeral from 1 to 5. So for the first alphabet, uh, it clarifies the chamber that is being paced. So the parameter is well annotated here. Chamber paste, which is the first alphabet. So the second alphabet means the chamber that is being sensed. So when we use the word chamber paste, are we pacing the atrium or the ventricle, or we are pacing both chambers, which we call dual? This mode also goes for ICD and then CRTDs. Okay, so chamber paste, second alphabet describes the chamber that is being sensed. Either it's the atrium or it's the ventricle or both chambers. So the response to sensing. So the response to sensing means, are you inhibiting sensing or triggering pacemaker, or you are responding to both? Meaning that so inhibit simply means when you sense, do you inhibit pacemaker discharge? Trigger means you just trigger the discharge, not you don't mind the sensing. And dual means that you do both. Okay, that means if you need to inhibit, you inhibit. If you need to trigger, you trigger. Or no response. None, no response. Okay, so the fourth is the rate modulation, meaning that rate modulation describes response to physical activity. So it simply means that when a pacemaker has been usually programmed between its lower and its upper limit rate. So we have the lower rate limit, meaning that lower rate limits that can be programmed as 50 beats or 60 beats per minute. So it means that anytime the patient's heart rate, intrinsic heart rate, drops below 50 beats per minute, and the pacemaker will kick up if the lower rate limit of that pacemaker is 50 beats per minute. Its upper rate limit uh, can be programmed at 130 beats per minute. So it means that when the patient needs to do activity that can take him as high as up to 130 beats per minute, and his own intrinsic activity cannot go that high, and the rate response will kick in to increase the heart rate to at least its upper rate limit. Now, so this rate modulation, how does it work? So you expect that when someone is sleeping at night, he's not doing any much activity, right? So it can have its lower rate limit at that time. So just the same way, every sleeping heart rate is usually the lowest, right? Compared to when the person wakes up and needs to run or to catch a bus. So, or to climb the flight of stairs. At that time, his heart rate increases. So if your pacemaker does not have an upper rate limit, let's say pacemaker rate is just 60 beats per minute. By the time patient is running at a rate of 100 beats, 120 beats, the patient will soon have been having syncope because the heart rate cannot cope, the programmed heart rate cannot cope with the current activity the patient is doing. So that's why you always need to turn on this rate modulation, especially in young people, in young middle-aged people that still do very strenuous physical activity. So their rate limit should be turned on. So on a normal day, when some patient has a dual chamber pacemaker that is pacing both chambers and sensing both chambers, that would be D for dual chamber paced, dual chamber sensed. And if the response to sensing is both inhibit and trigger, then it will be the third D. And if you switch on the rate modulation, meaning that to cope with physical activity, then the patient would have a coding called DDDR. Okay, I guess that's clear. So if the only chamber you paste that your patient has one electrode, single chamber pacing, and it's just the ventricle, that means if the electrode is one single electrode that is in the ventricle, that means it can also only sense the ventricle. Now, you can either turn on the dual of the electrode to inhibit and trigger, or you just want to inhibit only. Inhibit when is, that means that stop, moment you sense, avoid pacing. Inhibit. So if you are only using inhibit, then the patient will have a VVI mode. If you are going to use both inhibit and trigger, then you have a VVD mode. Then you can switch on your rate response, which will be hidden. So the patient can have a VVIR pacemaker coding. So whatever the code you give the patient, just know that it's going to fit into this table, this plan. So for the fifth column, it talks about multi-site pacing. So multi-site pacing or antitachycardia activity. So the fifth column, I want you to know, is for both antitachycardia function and multi-site pacing, okay? So I'll explain what those two mean. So for the antitachycardia mode, we all know that when a patient has an ICD, it has the capacity to shock the patient, okay? So that is where this comes in. And an ICD also has the capacity to pace the patient, right? Good. So if you are doing both with the ICD, then it will be dual. Also, this fifth column also works for multi-site pacing. So multi-site pacing simply means that if you are pacing different sites in a particular segment of the heart. So we have two segments of the heart, the atrium and the ventricle. So for example, if the patient can have biventricular pacing, right? So that's CRT. So you are pacing two different sites in the ventricle, left and right ventricle, right? So that is a multi-site pacing, okay? So that is where a BiV would also come in to place. Okay, all right. So if that is clear, do you have any question on this? Because most of the slides now is actually going to be teasing out what this table represents. So do we have any question on this table? I hope I'm still audible.
Yes, Prof. You're still audible, please.
Okay, so if there are no questions.
Yeah, Prof, just a little, when you
Louder, sir.
guys,
Louder, sir.
yeah, Prof, are you hearing me, sir?
I'm trying to.
Okay, okay. Are you hearing me, sir?
Okay.
Are you hearing me, sir?
Okay, I'm trying. Yes, yes, yes. Let's hear you.
Okay, so I want to find out, initially you were talking about the leads, and you made mention about leads that were, when you screw the leads at the atrium or the right ventricle. right atrium, right ventricle. You made some comments that I didn't seem to get those comments
Sorry,
about
I
potential stimulation.
I don't know if it's my speaker. Okay, I think it's my speaker. Let me increase my speaker. Okay, can you say it again now?
Okay, so Prof, I was saying that in when you are talking, you made mention about your electrodes, screwing your electrodes in either the right atrium or the right ventricle. And you
Yes, sir.
also talked about that there could be some complications that come out in MCQ. I think I didn't seem to hear what you said.
Oh, so my network was not loud. Okay. So you mean discussing this, right?
Yes, sir. Yes, sir.
Yes. Good. So I was saying that in MCQ, there can be an MCQ that which of the following causes diaphragmatic stimulation as a side effect of pacemaker implantation? A, ventricular, right ventricular electrode. B, left ventricular electrode. C, right atrial electrode. D, none of the above, all of the above, something like that. So just trying to make you know that diaphragmatic stimulation can happen by any of the electrodes. Either it's the right atrial electrode, the right ventricular electrode, or the left ventricular electrodes. And no when we say left ventricular electrode, that's the CRT electrode that goes into the coronary sinus to the back of the left ventricle. Okay? So that'll be biventricular pacing. So any of those electrodes can cause diaphragmatic stimulation. So let's take them one by one. Let's start from the right atrial electrode. So when you screw in the right atrial electrode, I said the right atrial appendage is very thin wall, so it's very easy to perforate it. And the nerve that runs around this right atrium is the phrenic nerve. And we all know that the phrenic nerve supplies the diaphragm, right? So if you screw in and perforate the right atrial appendage, the next thing you'll be stimulating will be the diaphragm, okay? And so when you stimulate the diaphragm, the patient can have stimulate the phrenic nerve. And from the phrenic nerve, the patient can be having diaphragmatic stimulation. Okay, is that clear, sir?
Yes, sir. Yes, sir.
Okay, so the second is the right ventricular electrode. You can see the location of the right ventricular electrode in the right ventricle. It's very easy for you to perforate the inferior wall of the right ventricle, and the next tissue you'll be touching will be the diaphragm. So that'll be a direct diaphragmatic stimulation. Do you get that, sir?
Yes, sir.
So the third is the left ventricular electrode that goes into the coronary sinus. So it's, when you're passing through the coronary sinus, one of its tributaries drains the inferior wall of the left ventricle, okay? And you can go through that vein so deep that you'll be touching the diaphragm. And you can also go so lateral that the phrenic nerve, which is bathing the heart at the left border, the left phrenic nerve, it directly baits the left border of the heart. You can be stimulating it. So if you are stimulating the phrenic nerve, or you are directly reaching the diaphragmatic wall, that can also cause diaphragmatic stimulation. Okay, so whatever the electrodes, they are all likely to cause the complication of diaphragmatic stimulation. So that is why when we are doing the procedure, we usually tell the person doing the programming, moment to insert the electrodes, either any of the electrodes, and we are testing them on table, we usually go to the highest voltage of discharge so that we will be sure you are not stimulating the diaphragm at the highest voltage. So if you are not stimulating the diaphragm at the highest voltage, that means that when you are at the lowest voltage, you are very unlikely to stimulate the diaphragm for each of the electrodes. Okay? So we usually test that. Because the challenge will come when you don't test it and patient comes out of the theater, and by the following day, they are just having hiccups, and this patient is now pacemaker dependent. So that means that every cardiac cycle, the patient is going to have hiccups. That can be very troublesome. right? The patient will just tell you to go and remove the pacemaker because you are not giving them peace. So it can be very, diaphragmatic stimulation is a very troublesome thing. Okay? Hope that clarified your question, sir.
Very clear, Prof. Thank you very much.
Thank you. Any more questions? Okay, so I guess we can proceed. So we've gone through this and this coding for the pacemaker. Okay, so next, we've already described all this, that the first letter described the chamber paced. We said the second letter describes the chamber sensed. And the third letter describes response to sensing. Either you want to trigger pacing or inhibit pacing when you notice intrinsic activity, or you're going to do both pacing and inhibiting. That's the dual. Okay? We've already informed previously that when a patient does not, the O end of it means none. For each of those alphabets, the O means none. Okay? So for example, a patient can have dual chamber pacemaker, but you are not allowing it to sense, so it will be none. And you are not allowing it to respond to sensing, so it will be none, 0. So the patient will just be paced because you said it's a dual, is to pace the chamber, but you should not sense the chamber. Okay? So that would be a DOO. Okay? Now, there's another important thing. I want to come to this table once again. This table, I need to come back to this table to show us something. So there are some electrodes that is a single electrode, but the way it is designed as a single electrode, it can recognize both the atrium and the ventricle. Remember, I said it's a single electrode, meaning that it is placed in the ventricle, but it is so designed that it can sense both the atrium and the ventricle. Okay? And it can either inhibit or trigger. So in that kind of coding, it should be V, because it's in the ventricle to pace. It can only pace the ventricle, but it can sense both the atrium and the ventricle. So that would be D. Then it can either inhibit or trigger or dual. So you can have a VDD or VDI or VDT. Okay? I need us to know that is a form of programming. Secondly, another form that has been made recently, we said pacemakers have been modified so much that they are now bullet size. I'm sure we've seen the bullet size pacemaker before. Picture. We can all browse it. It's not like a bullet where you just deliver them into a particular chamber. So most ones they make now, you deliver them into the, I just want to bring up a picture of the bullet size. So they now deliver them straight into a particular chamber. So most of they make now, they make them into the ventricle. Okay, bullet size, they are the recent bullet size pacemaker. Now, one important thing about this bullet size pacemaker is that the most recent ones they make now, it will be in the ventricle. So let me stop sharing and share this, share the whole screen. So this bullet size, which you can see on our screen, you can see it just like a bullet. Now, so the recent ones they make now, you go and implant it in the right ventricle. You pass a catheter from the femoral vein, the same way you are doing a cardiac cath. And through that catheter, you push it into the ventricle. So it sits down in the ventricle. So now, Medtronic makes, St. Jude makes, or Abbott. Now, one important thing we should know about this bullet is that the recent ones they are making can sense both the atrium and the ventricle, but it can only pace the ventricle because it's going to only sit in the chamber. It can only pace the chamber it's sitting in. So the recent ones they make now, you can sense both. Now, so that can either, so this kind of battery, we call it leadless pacemaker. It can pace and it can sense. It has an average lifespan of like 15 years. Okay. So usually useful when a patient that does not have good venous access or patient has been having infection of the pocket or where you put the pacemaker batteries. So to reduce the risk of infection, it's easy to just go and implant straight into the chamber. Okay, so these are things that can come out in our it can come out in the Viva station. Okay, so it's important we know about them. Okay, so I'll go back to the presentation. Okay, so we can back to slideshow. Hope my slide is showing.
Yes, Prof.
Thank you, sir. Okay, so we've described the different segments of the pacemakers when giving the codes. Okay, so one important thing here is that when you use a single chamber pacemaker, you will not be able to achieve synchrony. So, for example, if you are just pacing the atrium, sometimes it might be difficult because you are not coordinating both atrium and the ventricle together. Synchrony can be lost at sometimes. But if the patient has a good AV nodal function and the patient has a dysfunctional SA node, we all know that when you pace the atrium, it will conduct to the AV node and you can generate the normal ventricular activity that you can synchronize if the patient has a good AV node function. But if there's no good AV node function and you are just pacing the atrium, it will not translate to the ventricle. So that's why it's said that, and one important thing we should know clinically is that when a patient at the early stages of SA node dysfunction, you might be tempted as a doctor to just go and put a single pacemaker, single chamber pacemaker in the SA node because you think that AV node is functioning now. But don't forget that the disease, the fibrosis happening in the SA node also have good tendencies to catch up with the AV node. So in the long run, patient can now also progress to a AV node block, okay? And patient will now be needing a dual chamber pacemaker at that time. So it's just wisdom that the moment you see a patient has an SA node dysfunction, just give the patient dual chamber pacemakers. So let's leave the terrain where people still do single chamber pacemaker. So the only time you will wish not to do a single chamber pacemaker is if the patient has chronic atrial fibrillation. Because in chronic atrial fibrillation, the atrial lead will just be sensing fibrillation and it will be patching it down to the ventricle. And that will be a problem for the ventricle. Okay? So it's only when the patient has a chronic atrial fibrillation you can consider doing a single chamber pacemaker, which is pacing the ventricle. But for SA node dysfunction, complete tab block, AV node dysfunction, please, a dual chamber pacemaker is the best bet for patients. It has long-term clinical outcome for proper synchrony between both chambers. Okay. So for single chamber coding, we've actually described before. If you are pacing the atrium alone and you are sensing the atrium alone to be AA high, PV high, if you are not, we've already described all these codes, AOO, VOO. VOO will be useful when you have a patient that will be needing a surgery and will be using diathermy. So because of interference with sensing of the ventricle, when the patient is using the diathermy or anything that will influence myocardial potential, that will be making the pacemaker to oversense intrinsic activity that is not there. I want you to get the word very well. Any stimulation of the muscles, myocardium, that is not generating proper action potential, that is not generating proper depolarization, will make the pacemaker feel that there is intrinsic activity and it will not make it pace. Such is diathermy. Such is when patients are engaged in drilling activity, mechanical drilling. You know, these drillers that drill things, that drill road, that drill borehole, that drilling machine generates a lot of myocardial potential. And that confuses the pacemaker lead as intrinsic activity of the myocardium. In those kind of states, it's very dangerous. The patient can be in asystole because the patient is not having proper intrinsic activity. So the pacemaker is confused from the myocardial potential, thinking it is normal intrinsic activity. So if the pacemaker fails to pace at that time, patient can go into asystole. So to prevent that, that's why we put the patient on VOO. Okay, so that's the only benefit of a VOO. Okay, hope that is clear. So when the patient has a dual chamber, we said you can program in any of these modes. So DDI, DDD, VDD. Remember we discussed VDD. So I told you that there are some pacemaker electrodes that is for a single chamber, but it's modified in a way that it can recognize both the chamber it is pacing and the atrium. So it can recognize both the ventricle and the atrium intrinsic activity, but it can only pace the ventricle. Okay? So because it can recognize both the atrium and the ventricle, the sensing, the second alphabet will be D. And it has ability to either inhibit or trigger activity. So the third alphabet will be D. So that would be a VDD. So VDD is a very possible programming mode. So don't let us get confused. So don't say that, oh, Shebi is only single chamber. Why are we not having a D to sense? It's because it has been modified in the nature, the modification they made on that electrode means that it can both sense the atrium and the ventricle at the same time. Okay. All right. So now we now ask ourselves, what is the advantage of one mode over the other? So let me just quickly discuss this. So we can have a VAT, I just described that. A VTT mean that it triggers only, you don't have to inhibit. It depends on what all this programming are not usually done, but are possible on the machine, on the programmer. Okay. So I want to use this slide to describe what is the advantage of a DDD over a DDI. What will be the advantage of a VVI over a DDD and vice versa? I want to use this to make an analogy. We've already said that AHOHO, VOHO is, it cannot synchronize at all. You cannot synchronize both the atrium and the ventricle because you have told it not to sense and it should not respond to sensing. So there's no synchrony you can achieve on that. So AHOHO, VOHO, DOHO are asynchronous modes of pacemakers. And we have told you, we've described the clinical scenarios where you use them. When the patient has high risk of the pacemaker oversensing, especially when a patient is doing a surgical procedure or a patient is doing some mechanical work, that will confuse the pacemaker of recognizing electrical muscle potential, but not knowing that it is not a normal myocardial activity. So at that stage, the pacemaker will not pace and the patient can go into asystole. So in order to avoid that myocardial potential being recognized as electrical activity of the myocardium, you would change the pacemaker mode to an asynchronous mode so that it does not recognize intrinsic activity or confuse itself with intrinsic activity, to just continue to pace throughout the period that the patient will be doing that procedure. Okay, but for synchronous mode, meaning that you are having ability to synchronize with the patient's intrinsic activity, meaning that the pacemaker, you have coded it or you have programmed in the way to recognize intrinsic activity of the heart. So either it's a DDD or a DDI or AAI, these are all synchronous mode. Now, one important thing here, I think something is not showing on the slide there. VDD is the one under the AAI. There's VDD under here. Okay, so one important advantage of one over the other here. So let's discuss advantage of one over the other. So AAI, when you use AAI, you just do AAI in when you think a patient has pacing to respond to a pacing demand only, pace demand only. So this is a patient that just has SA node dysfunction, and so the AV node is functioning well. So you put in an AAI mode. Even if the patient has a dual chamber, you can give him an AAI mode to tell the patient that, okay, when the SA node goes bradycardic, that is when the atrial pacing should kick up. And when the atrial pacing kicks up, the patient would have his normal intrinsic ventricular activity. Okay? Remember, we said at this stage, you are only pacing the atrium because the patient has a good AV node function, right? So when the patient has sick sinus syndrome, you can just put it in AAI mode. When the patient goes into sinus bradycardia, the AAI mode kicks up and is going to follow its normal intrinsic activity of the AV node and the ventricle. Okay? That's just the benefit of an AAI mode. When the patient is now, the I portion means that when the patient is now going into sinus tachycardia, you know, sick sinus, they can go into tachybradism. So the tachy end, the AAI, the I component will recognize intrinsic activity in the atrium. So it will inhibit pacing. So at that time, you will not be over pacing so as not to generate ventricular tachycardia. Okay? So that's the purpose of the I components of the AAI mode. VVI mode. What's the benefit? So VVI mode simply means that you're only pacing the ventricle, you're only sensing the ventricle. Now, I portion tells you that you are going to inhibit if you sense intrinsic activity. Now, it means when a patient that has AV node block, SA node is functioning well, but the AV node is dysfunctional. When the patient goes into bradycardia because of the AV node block, the pacemaker will kick up. When the patient has normal intrinsic activity, the pacemaker will back down. It will inhibit pacing. So that's just the benefit of the VVI mode. Now, one advantage of VVI mode here now over the DD components is that when the patient has chronic atrial fibrillation, remember the atrium will be running at a rate of 250 to 350 beats per minute. You don't want the ventricle to run at that rate. So the ventricle would disconnect from the atrium. And so it will be running at the rate at which you program it to run. Okay? So in that kind of case, you put a VVI mode in a patient that has chronic AFib and a complete heart block. So for the complete heart block, the VVI mode would be pacing itself at the program set rate. While since there's no atrial component, it will not respond to anything coming from the atrium. So that is the benefit of using a VVI in chronic atrial fibrillation. I get this part of the questions that in the Brownwood question and answer review board question. So a DDD mode. So a DDD mode means that you are pacing both atrium and ventricle. You are sensing both atrium and ventricle. You are responding to either inhibit or trigger. Okay, this is what you want. What you want when a patient has SA node block or complete heart block, because you want to synchronize both the atrium and ventricle together. You want to be able to place both chambers. You want to be able to sense both chamber and respond to pacing, intrinsic activity, and trigger when necessary. Okay, so this is ideal for a patient. But the shortcoming of DDD mode is that when a patient goes into atrial fibrillation, remember that the second D is sensing both chamber. So it's going to be sensing high atrial rate, right? The patient can go into rate of 250 and things like that. It's going to sense high atrial rate. Then it's going to be responding to that sensing by triggering the ventricle, because it's pacing, it has the ability to both pace both atrium and ventricle. So it's going to be triggering the ventricle to also go at the atrial rate, because it wants to synchronize atrium and ventricle together. So if you are pacing the ventricle at 250, because atrium is running at 250, then you're going to VT and VF, right? So that is, you don't want to use this mode when you suspect patient has tachy, very high atrial episode like atrial fibrillation or atrial flutters. Okay. So in that situation, then you will do a DDI. So what does a DDI do for you? A DDI, the I component helps you to inhibit pacing, especially in the ventricle or in the atrium at when very necessary. So let's look for example now. When you program a DDI, you program it at upper rate limit can be 130 beats per minute for both chambers, okay? So that means ventricle has a upper rate limit program as 130 beats per minute or 140 beats per minute. So when the patient goes into high atrial rate of 250, maybe he has atrial flutter, goes into 250 beats per minute. Because the upper rate limit you have programmed the ventricle is 130 beats per minute, this pacemaker will never, ever pace the ventricle above 130 beats per minute. So you can see it helps you to checkmate the ventricle from pacing beyond the upper rate limit. So that is what that inhibit will do. So if the ventricular rate is getting to above 130, it will continue to inhibit its function from pacing. So that's just the benefit of a DDI activity. So the down part of it is that as long as the ventricular rate is between the paced program rate. So what is a paced program rate? That means between his lower rate limit to his upper rate limit. So if you put it lower rate limit at 50 beats per minute, upper rate limit at 130 beats per minute, any ventricular activity that falls between 50 to 130, this pacemaker will inhibit, it won't pace. So meaning that the patient has a ventricular rate of intrinsic ventricular rate of 60 beats per minute, the pacemaker will not pace. But remember that the patient can have a sinus rate of 100 beats per minute, 120 beats per minute. As long as you are putting in beats, the ventricle will not pace at that same 120 beats per minute. So that's just the shortfall of the DDI. But if it was a DDD, It means that if the patient has an atrial rate of 110 beats per minute, and the ventricle is on its physics is running at 60 beats per minute, the DD component, the trigger component, will increase the ventricular rate to also 100 beats per minute or 120 beats per minute to catch up with atrial rate. So DDI has a safety margin for you in the sense that it will not allow you go beyond the program paced rate. So it will also not allow you go into the atrial rate that is going into a flutter rate of 250, 200 beats per minute. So that's one benefit of a DDI over a DDD. So it means that when a patient comes for pacemaker programming, patient has a dual chamber pacemaker, and you start programming the patient, dual pacemaker, and you notice that at a particular time of the day, the patient had a high atrial rate or atrial flutter of 250 beats per minute, which made the ventricle to also go at a rate of about 200, 250 beats per minute, making the patient uncomfortable. Because the patient is in DDD mode, you can do a mode switch for the patient from a DDD mode to a DDI mode. So the DDI mode simply means that when the patient goes to a rate of 250 beats per minute, as long as his ventricular rate is between the programmed rate, between the lower rate limit to the upper rate limit, it will not allow the ventricular rate to go beyond the upper rate limit. So it will continue to inhibit, even though the atrial rate is going to 250, 300 rates. So it can help you checkmate an atrial flutter. Hope this is clear. Hope I'm still audible. Hello?
Yes, Prof. You're audible, please.
So please, do we have any question on this at this stage? This is very important for you to know the difference between a DDI and a DDD. When does it benefit a patient? Any question on
Prof,
this?
can you take it again? Can you take it again, sir?
Okay. I'll explain again because this is very important. So you have a patient that has dual chamber pacemaker, right? And because the dual chamber pacemaker, it can sense both the atrium and ventricle. So that gives you another D, right? Then it can inhibit and it can trigger, right? So that's the third D. So remember this, the function of this is that the DDD means that if atrial rate is 100 beats per minute, for example, because it can sense both atrium and ventricle, and it's synchronizing atrium to ventricle, you would expect that the pacemaker will also increase the ventricular rate to 100 beats per minute. That's the function of this D. Atrial rate went to 100 beats per minute. You would expect ventricular rate to also to go to what? 100 beats per minute. So it means that if atrial rate is 100 beats per minute and the ventricle is still in 30 beats per minute, because it has complete that block, the pacemaker will pace till the ventricular rate is catching up with the atrial rate at what? On both 100 beats per minute. So that's the function of the D. It will continue to trigger until you achieve both 100 beats per minute in both atrium and ventricle. Question now ask yourself is, what if atrial rate goes to 250 beats per minute? Then his duty is to also try to pace the ventricle to catch up with atrial rate, Abi. So you can go as high up to 250 beats per minute. Are we getting that, sir?
Yes, sir.
Okay. Because he wants to synchronize atrium and ventricle. But we know this rate is very deleterious to the patient, right? So patient can go into paroxysmal AFib, paroxysmal atrial flutter, and the ventricular rate can also go that high, which is dangerous. So you don't want that, right? So in a patient you suspect that can be having proximal atrial fibrillation. So what should you do at that time? Then that is where you have your DDI mode. You want to use the high as much as possible. So it means that anytime the patient goes into far above your program set rate, we said you, for a pacemaker, you always set the rate for the pacemaker on the machine. You are the one that will choose the lower rate limit and the upper rate limit. So you will tell it that, okay, I want you to pace when the heart rate is going below 50, kick up pacing. When it's going above 130, don't bother pacing. So if you have that setting, it means when the patient goes into proximal atrial flutter of 200, 250 beats per minute, as long as is in a DDI mode, the I will inhibit the ventricle from going above 130 beats per minute. You get that? So patient can, atrial rate can run at 250, 300, 350. It will not bother you because the ventricle will never go beyond the rates at which you have set it. At that time, it will switch from following the atrium. It will now switch to just be pacing its ventricle at its ventricular set rate. Do we get that, sir?
Yeah, yes, Prof.
So I just want us to see the little minute difference between a DDD and a DDI.
But Prof, I have a question.
Yes, sir.
But Prof, in a DDD, since the I is also in the, because it's dual, why can't a DDD also do that inhibitory function?
Yes, we know. Yeah, sure. We are getting you. It has that dual function, okay? But what you should note is that it has ability to both trigger and inhibit at the same time, right? Switched on. Remember, it's DDD always want to make beats synchronous between atrium and ventricle. So as much as possible, it always wants to avoid asynchrony. So in that case, if the heart rate is going 180, 190, I'm telling you, your DDD can go that rate. Okay? It has the capacity to go that rate, even though you have set it at upper rate limits. We've seen that in pacemaker clinic many times. That's what I'm telling you. So when they come for programming, patient that goes into plasma AF, and they will tell you they have been having shortness of breath, they are getting easy fatigue, dizzy. When you go to interrogate their device, you find out that there are sometimes they have very high atrial rate, and that culminated in high ventricular rate. Are you getting it, sir? Because your DDD mode always wants to maintain synchronous beat as much as possible. Hope you get it, sir.
Yes, Prof, it's clear.
So
It's clear.
we switch them to this form of DDI. It's remove the triggering effect, okay, to make it as at a point asynchronous, meaning that you will just knock off atrial activity and you just be on ventricular activity alone. So maybe one of these days I will try to look through our archives to bring out some of these tracing, pacemaker tracing, so that you will see the problem when they go into very high atrial rate, then which culminates in high ventricular rate because of the DDD mode. Okay, so that is part of the subtle differences, sir. DDD tries to, as much as possible, to maintain a synchronous beat. A DDI can, at a time, switch for you when atrial rate becomes erratic. Hello?
Yes, Prof, thank you, sir.
Any questions at this stage? Yes. Okay, so we want to go into some modes. We sure we don't have questions, so we can go into some of these modes. So when you are looking at an ECG tracing, sometimes, but not always, I'll say few times, you can decipher what type of pacemaker mode a patient is having. So, for example, we said the patient can be in a VO mode, which is an asynchronous mode. It simply means you have programmed it to know when to pace and when to sense. But because a VO mode, it will not respond to sensing, it would not sense, and it would only pace. So for example, you look at this ECG tracing, we both can see a QRS activity, right? You see intrinsic activity in the myocardium, but the next beat after it is a paced beat because we can see the pacemaker spike and we can see that the QRS is a little bit different from the intrinsic QRS. So that means that, and if you look at the time interval here, this should be a patient, the ventricular rate here will be like 200 and something, right? One small box, you get. So it means that this pacemaker did not respond to this intrinsic activity. Okay? And it continues to pace. So look at this next intrinsic activity here. Look at how close the pacemaker spike is to the intrinsic activity. Even though the myocardium did not depolarize with following this pacemaker spike because it's still at the absolute refraction. So that's why we didn't generate any proper action potential. Then you can see that it continues to do the spacing. Another second thing you notice that the pacemaker spike is coming at a set rate. So it's going to be like 4 boxes from each other, meaning that that is a set rate at regular rates. Even though intrinsic activity came in between the rates, it did not recognize it. So that means it's not sensing the ventricle. It's not responding to sensing also. And so it's just pacing all through. So that, and number 2 is that you can only see a single pacemaker spike. We are not seeing any pacemaker spike in front of the P wave. So that tells us that this is pacing only in the ventricle and is not pacing the atrium. So this we can say is a VO mode. Any question regarding this? You have any question regarding this?
Please,
Okay.
sir, can you just do it again?
So I said, number 1 thing, first thing is that you can only see one pacemaker spike, right? So that tells you that most likely you're only pacing one chamber because you can only see one pacemaker spike, which is close to the QRS, right? It's generating the QRS potential. We didn't see anyone in front of the P wave, right? So that means we are not, as long as you are not seeing a pacemaker spike in front of the P wave, is maybe the patient does not have a lead in the atrium. The pacemaker spike you can only see is generating ventricular activity. When it paces, you see it generate ventricular activity. So that tells you that it's pacing the ventricle. Number two is that we can see intrinsic activity of the patient. And shortly after that, you're seeing a pacemaker spike. Because if the pacemaker actually senses this intrinsic activity, then it should withhold pacing, Abi, and wait for the next cycle, which should be like 4 boxes from the intrinsic activity before it generates the next pacemaker spike. But between this pacemaker QRS and this pacemaker spike, it's like 200 and something beats. Do we expect a pacemaker to be giving us a rate of 200 and something beats? No, it should not be programmed that way, right? So that means it did not respond, it did not recognize this intrinsic activity. Another example would be at the 4th beat, at this 4th cardiac cycle, you see a pacemaker, a QRS, and a pacemaker spike is just like 2 small boxes afterwards. We don't expect a pacemaker properly programmed to be generating another spike just close to the T wave. No. So it tells you that this pacemaker is not recognizing this intrinsic activity. So the question we ask ourselves is that which chamber is it pacing? The ventricle, because we can see when it paces, it generates QRS, it's pacing the ventricle. Is it recognizing the intrinsic activity in the ventricle? Absolutely no. It's not recognizing it because this intrinsic activity, why should you pace immediately after intrinsic activity? So it tells you that it's not sensing the intrinsic activity. So it's not responding to sensing. So do you now understand why it is a VOO mode?
Yes, sir. Thank you.
Okay. And we gave indications why we use a VOO mode. We gave indications when you think the patient is going to go for a surgery and you're going to use a diathermy because you don't want the pacemaker to be sensing muscle activity, which is not myocardiac activity. Because every time you use the diathermy, there is action potential generated in the muscles, right? Myocardiac activity. She gets electro EMG, okay? It does not mean that that is the normal cardiac activity that is happening. So those patients can go into a study because the pacemaker will just be sensing muscle activity and not myocardium activity. So in that kind of a patient, they can go into a study. So you have to program them as VOO mode to tell the pacemaker, don't sense, don't respond to sensing, just keep pacing at a set rate. Set rate for this patient is 1, 2, 3, 4. 300 divided by 4. And that's 60, right? You just tell the pacemaker, pace at 60 beats per minute. Either you sense intrinsic activity or not, keep pacing at 60 beats per minute. Okay? Is that clear? Any question on this? Okay. So no question, we can move on. So usually done when you need surgery, that time will be used. Okay, so let's see the difference between that first ECG and the second ECG. So this second ECG is a patient where you have intrinsic activity. So let's take it from the beginning. We're only seeing one pacemaker spike, right? In front of the QRS. Okay? And intrinsic activity is there, and you do not see any pacemaker spike around it. So seeing one pacemaker spike that is generating QRS, paced QRS, that tells you that you're only pacing the ventricle. We have not seen any other pacemaker spike in front of the atrium. So likely it is just a single chamber pacemaker Now, when you notice intrinsic activity, you did not see any pacemaker spike around it. So that means it recognized that intrinsic activity and it inhibited the spacing, delayed the spacing until the next intrinsic, until when that you saw a P wave, but there was no intrinsic activity, so it paced again. So that will be that this pacemaker is only pacing the ventricle. The pacemaker sensed the ventricular activity and it inhibited itself from pacing when it sensed the ventricular activity. So you can now understand why it is a VVI mode. Any question? Do we have any question on that? Okay, so if there's no question, we can move on. So we all know indications for a VVI. We said when the patient has chronic atrial fibrillation, you don't want to be pacing the atrium at that time, right? And you don't want to be sensing the atrium at that time, or else the patient can go into very fast erratic ventricular rate. Okay? Yeah, so it's important to state that anytime your patient has AFib and is on pacemaker, please, it's always important to put them on anticoagulants. It's a classical indication for anticoagulants. Please, it's important. Because that pacemaker does not mean you have treated the atrial fibrillation. So you need anticoagulant. It's also important to state that even if a patient does a EP ablation for atrial fibrillation, they must still continue anticoagulants. Please. I just came to my mind to state that. Okay. So let's look at this next ECG. So number one is that if you look at it again, we are noticing one single pacemaker spike. But one beautiful thing at this stage is that it's not related to the QRS. Okay. The pacemaker spike is not related to the QRS. Rather, it's related to the P wave. Right? So you can see the shape of this P wave that is paced is different from this intrinsic P wave. Right? This intrinsic P wave is different from the shape of this paced P wave. Right? So we can see the paced atrium. We notice that when we have the normal intrinsic atrial depolarization, we didn't see the pacemaker spike. So that means it has ability to recognize intrinsic pacing at the atrium. So that means the chamber paced is the atrium. The chamber sensed is the atrium, because when it sensed intrinsic activity, it didn't pace. And it inhibited the spacing. So that makes it that this is an AA high mode. Do we have any question on this? We never saw any pacemaker spike related to the QRS. So that means there is no ventricular pacing in this mode. Okay? Please, it's also important to state that a patient can have double chamber pacemaker, but you as a physician can program the mode to whatever mode you choose. So for example, patient can have dual chamber pacemaker and you program the mode as AA high. It will function as AA high, even though it is dual chamber pacemaker. The same if you program it as VV high, it will function as VVI, even though there are two pacemaker leads in the patient, atrium and ventricle. So it depends on the mode you switch on. That is how the pacemaker would function. Any question? So we've already described the indication for using an AA high mode. Okay? All right. So remember, we said there are some electrodes that can, so for example, this is an electrode that has ability to pace, is a single electrode, but has ability to sense atrium and ventricle. So it can only pace the ventricle, but can sense atrium and ventricle. Okay? Now, one important thing is that it will be difficult to make that diagnosis on an ECG. You can only notice that when you are doing the programming. So its ECG will function like a VVI. Okay? Meaning that, but one good thing it will do for you is that it can help you synchronize activity. What do we mean by synchronized activity? So it can track every P wave and let the QRS follow the P wave. So let's look at this EKG, for instance. This normal intrinsic P wave. This is normal intrinsic QRS. So the pacemaker sensed the atrium and sensed the ventricle, and it inhibited the spacing. Okay? Now, we didn't see any P wave, right? But because the pacemaker has a program rate of like 60, this is like 75 beats per minute. When the time interval between this intrinsic activity and the 75 beats per minute reaches, and it does not sense any intrinsic activity, it has to pace. We said the pacemaker is programmed at 75 beats per minute. How did I know? Look at the distance between this pacing spike and this pacing spike. If you count the number of small boxes and the number of big boxes there, it will be like 75 beats per minute, right? So, between the intrinsic activity and the net 75 beats per minute, if it didn't sense any activity, so it had to pace. But if you notice that when he paced, you didn't see atrial pacing. You only see ventricular pacing. That means that the pacemaker did not have capacity to pace the atrium. So it can mean it can only pace the ventricle. So that tells you that the chamber paced is ventricle. Okay? Number 2 here is that it sensed atrial activity. Okay? It has a PR interval. So anytime especially when the patient has a dual chamber pacemaker, or it has ability to sense atrium and ventricle, it will give you option to set a PR interval in your pacemaker programming. So you are the one that will choose, I want a PR interval of 180 beats per minute, 200 beats per minute. So it sensed PR interval. So if the PR interval is not getting beyond the time you set, it's going to pace again. So that means that this pacemaker has the ability to what? Sense atrium because it determined the PR interval. Let's go to this guy. Let's go to this guy. This is a VVI mode. VVI mode here is set at 4 beats, maybe less than 75 beats per minute. Let's just say 60 beats per minute. Because it's a VVI mode, you can't set a PR interval because it can't recognize the atrium. So how will you set a PR interval? It can't recognize the atrium. So that is why you will see a P wave here. But it cannot follow a PR interval. It can only recognize heart rate that you set it paced at 60 beats per minute. So when the next 60 time for the next 60 beats happens and you don't see a QRS intrinsic activity, it's going to pace again. So either it sees it's not even bothered about the P wave. Look at the distance between the P and the QRS. So it's not bothered about the P wave because it's not sensing the P wave. So you can't set a PR interval. Look at the time interval between this PR interval. If you follow the PR interval timing, this is a very short PR interval. It should not have paced. But because its own pace rate is VV interval, 60 beats per minute VV interval. So between the intrinsic V and the next expected V of 60 beats per minute, if it does not see it, it will pace it. Do we get that, sir? So a VVI mode, what we are saying here, cannot work with a PR interval. It can only work with a VV interval. That differentiates it for a VDD. A VDD can work with a PR interval because it can sense the atrium. Then it can determine, with that PR interval, pace the ventricle. Look at this also, the last paced bit here. It senses the atrial activity, and because of the set PR interval, it can pace the ventricle within that interval, compared to the VVI mode we saw earlier. Is that clear? Any question? Is anything hard in this place? Let's know. Am I still audible?
Yes, you're audible. Sorry. In this one that is showing now, I can see some complexes after the second paced ventricle that are not paced. I don't understand what they're doing there.
Just tell me which cardiac cycle, third or fourth or fifth cardiac cycle, let me know.
The third and the fourth. No, the fourth and the fifth, sorry.
You mean this? Fourth is,
Yes.
This is 1, 2, 3, 4. This is a normal intrinsic activity now.
Okay.
Compare it to this. Compare to the first. Right? They look the same. QRS look
Yes.
the same, Q, right? But it's different from
Yes.
this, right? It's different
Yes,
from
it's
the
different from that.
in number 5, so patient can have VPC, right? It's not because
Okay.
of can have VPC for any reason. So if you have a VPC, the pacemaker should have ability to sense it, right? And not pace a VPC on Abi.
Okay, yes.
Okay. So that's why you saw that interval and the next. So hope we understood the mechanism between VV programming and PR interval programming. So for a VVI, it will only respond to the rate between the ventricular rate it's expected to happen. So meaning that if you set the VV rate at 60 beats per minute, when it's 60 beats time and it does not see intrinsic, it will pace. But if you program it as PR rating, it means that if it's 200 milliseconds and at 200 milliseconds after the P wave is not seeing ventricular activity, it will pace. But that pacemaker must be able to sense the atrium because that's the only way it's going to see a P wave. Abi? But in a pacemaker that cannot sense the atrium, you cannot be talking about PR interval. So that separates a VVI from a VDD. Is that clear? And that separates a VVI from a DDD. Because in a DDD, you can sense the atrium. So you can do a PR rating, PR programming. Are we getting it? But in a VVI, you can only pace the ventricle. You can only sense the ventricle. You cannot see any P wave. Is that clear? Any question? So we can move on, right? We'll soon round up because of time. I'll need to just random in this. Okay, great. So in a DDD, so we can see, yeah, sometimes you saw a single pacemaker spike, sometimes you saw 2 pacemaker spikes, right? So we can see a pacemaker spike in front of QRS here, So let's start from the beginning. You see a normal intrinsic, P wave QRS. There was no pacemaker spike. So that means the pacemaker that is there recognized atrial activity, recognized ventricular activity, so it didn't bother pacing. Next, recognize another atrial activity. There was no ventricular activity, so it paced, maintaining the PR interval, right? The next time, there was no P wave because of the time interval set. So it paced to generate a P wave. And at the same time, there was no ventricular activity because of the PR interval. It paced to generate the QRS. Okay, so that means it has the ability to pace the atrium. It also had the ability to pace the ventricle, right? So that means this patient would likely have a pacing lead in the atrium and a pacing lead in the ventricle. So dual chamber pacing. Okay. And afterwards, we didn't see P wave. It's paced for another P wave to generate. And good to know, the normal intrinsic ventricular activity came in. So, and it didn't pace. So that means it has ability to sense intrinsic activity and not pace on it. So that means it has ability to inhibit and ability to trigger. So that is a dual chamber pacing, dual chamber sensing, and response accordingly. Any question on this? Do you have any question on this? Okay, I think we're almost getting to that end. Do you have any question? Because I think this is actually the last end for the DDD. Dr. Eugene,
Yes, sir. Please, you're audible.
I just want to be sure there's no question from the group.
As at now, there isn't, sir.
Okay. All right, great. Okay, so because so we all know everything about temporary pacing. So I will just round up the slides with a few slides on malfunctioning. So we all know things about temporary pacing, epicardial pacing, either transvenous, transcutaneous pacing. We know a lot of information about that. We have the transcutaneous pacing pad. It can be used, the same defibrillator we use can actually pace. So that's the transcutaneous pacing. And we have the transvenous temporary pacing pacemaker lead. Can be passed either through the jugular, subclavian, femoral, any route, as long as it's transvenous. So I think there's an MCQ question on transvenous, transcutaneous, all those things usually comes out. We know that. I think I shouldn't bore us with all this that we know about temporary pacemaker, the machine, the cable will connect. So one beautiful thing I just want to point out to us about temporary pacemaker is that sorry, I'm coming out to. So in temporary pacemaker, you can also generate the same modes that you generate in permanent pacemaker. So that means you can have a DDD, you can have a VVI, you can have on the temporary pacemaker. So for example, for the Medtronic pacemaker now, if I come to this, so for the Medtronic pacemaker, in this screen, okay, let me use this. So in this, in the upper screen here, you can determine your ventricular rate. So yeah, the heart rate, I mean. Now, the pacing output, the threshold, you are the one to determine it by using this knob, okay? The threshold, that means the minimum energy required to generate action potential, the thresholds. So in this lower screen, there are many things, it carries many functions. But the function I want to bring out here is that the modes you want to select, either a DDD mode, VVI mode, AAI mode, all those modes are in this screen. So you can use this knob to select the mode you want. Okay? Asynchronous mode, whatever VOO mode, all those modes. And there's also an emergency button that goes into asynchronous mode, either the VOO mode or AOO mode or DOO mode. It just goes into that asynchronous mode for emergency reasons. So you plug your ventricular lead into the port for the ventricle. You plug the atrial lead into this atrial. So some other pacemaker have their different ports, but I mean the temporary pacemaker ports. But for Medtronic, this is the easier one. But one important thing is that there is a sensor here, green sensors. So if it is pacing, you will see it's pacing. If it's sensing, you see the flash, the flashing of the lights. The sensor will give you the green light. If it's pacing, if it's sensing, you will see there. So if it's not pacing, you will not see any lights. So please, you pay attention to these light indicators to let you know that you are functioning well. So if it's not sensing, you will not see the lead here. You will not see the indicator generate lights. So it's important. It uses normal batteries. So you can choose any voltage rate. So you are not afraid of consuming the battery. Okay, so that's what I'll just bring out in the temporary pacemaker setting. Okay, I'll just quickly go to some pace. So we've looked at normal pacemaker pacing spike above. We've determined there are different pacing modes. Now, so for this patient, it's just atrial that is pacing. So this would be like an AA high mode because it's only pacing in front of the P wave, atrial pacing. We're not seeing any pacemaker in front of the ventricle. So ventricular mode, VVI mode. Okay. So we are not seeing any pacing in front of the atrium. We're only seeing pacing in front of the ventricle. So this is, you are seeing pacing in front of the P wave and the QRS. So that's dual chamber, right? Okay, in this one, in front of the P wave and in front of the QRS. So that's a dual chamber speaker. Okay. Even this, you see this tiny spike here. So it's still dual chamber pacemaker. So in most patients you're going to see in the clinic, you might not see a pacemaker spike like that. And the reason is because they are using what we call bipolar leads. So bipolar leads means that the negative and positive electrodes, and the negative end and the positive end of the electrodes are close to each other. We said the tip and the ring. Okay, so let me just go to that slide that shows so that you know the reason why you don't see pacemaker spike on when you do ECG in a patient that has pacemaker like that. So for a bipolar pacemaker, we said the distal end, which is the tip, is the negatively charged. The proximal end, which is the ring area, is the positively charged. So let me show you on a live picture like this, that this metal is the positive end, the ring. This tip is the negative end. So that means the circuit runs between the positive and negative in this circuit. So that means that, and remember, this is already in the heart, in the myocardium, either in the right ventricle or in the right atrium. Okay? That's the bipolar mode. So it simply means that your surface ECG will not pick a pacing spike. Why? Because all the activity, all the electrical current activity is running in this short circuit. Is not getting to the surface of the chest. So the surface ECG will not pick that spike. Are we getting it? Because all the current is just running from this tip to this ring. Positive to negative, okay? In this circuit. Now, for a unipolar, what we said about unipolar is that the distal end is negative. The positive end is the battery, which is in the below the clavicle, right? So that means the electrical current is running from the negative to the positive, negative to the positive. So that means it has a wide circuit. So that wide circuit, the surface ECG is going to pick a wide circuit. Okay, so that's where you can see a very big pacemaker spike. Are we getting it? So that means that the surface ECG can pick this wide electrical circuit, so it's going to recognize that pacemaker spike very wide on the surface ECG. So it simply means that when the patient is on bipolar, you may or may not see the pacing spike because of the short circuit. But for moment to switch the patient to unipolar, there's a way you can do it on the programmer that you switch the pacemaker from bipolar to unipolar. If you switch that, you will see the wide pacemaker spike. Because unipolar means that it will only use the negative end at the tip and the positive end as the battery. You can do that programming and it will switch. Even though it's a bipolar lead, you can switch it to a unipolar lead. So in that kind of a patient, you will see the wide circuit and the pacemaker spike will be very big, gigantic on the ECG tracing. Hope we get that. So that when you see a patient in clinic and you're not seeing the pacemaker spike, don't say that there's no pacemaker spike, so it does not have a pacemaker. No, it might have pacemaker because the circuit is very short if it's bipolar. But if you tell them to switch the patient to unipolar, which they can do on programming, the spike will come out very broad, very visible. Is that clear? Okay. Do we have any questions? So that brings us to this kind of ECG in the sense that you will have to look deeply well to see the pacemaker, this tiny pacemaker spike in front of the P wave, and it's consistent. There's a tiny pacemaker. Sometimes it's there, sometimes it's not there. So for example, it is there in this one, this tiny dot, the pacemaker spike on the front of the P wave, simply because, as we said, it's a bipolar pacemaker and the circuit is very short. But if you change it to unipolar, you will see the very pacemaker as gigantic as this. This is like a unipolar mode, okay? So to round up, what are the challenges we can have with pacemaker? So pacemaker might fail to pace, okay? So remember we gave you an example that sometimes some patients are doing some activities that can affect their muscle potentials, right? So they can be drilling, and these muscle potentials will be giving artifact like this on surface ECG, and the pacemaker will be recognizing it as intrinsic activity. Okay? So if it's recognized as intrinsic activity, it will not pace. And that is very dangerous. So look at how long it took for this person to pace. So in that kind of case, it didn't pace. We expect that there should be a pacing spike here. Maybe if you set at 60 beats per minute, you should expect after 4 or 5 boxes, you should expect another pacing spike, another pacing spike, another pacing. So it did not pace for a long time. So that means that pacemaker was thinking that these potentials are intrinsic activity and is dangerous. So in this kind of patient, should be converted to VOO mode. Okay? So this is what you see when you're using diatomy, they are using anything that will increase electromagnetic potential. So it is oversensing, okay? So that is the problem here, okay? So in that kind of patients, it's important to change their mood. There could be other possibility. It could be that the battery is almost getting to end of life. It could be that there's a problem with the lead. Or it could be that it's just sensing and it failed to pace because it's sensing potentials. Okay? In this kind of patient, they can go into asystole. So if you look at these patients, we are seeing yeah, 2 pacemaker spikes. So we expect one for the atrium, one for the ventricle. Then later, you see a pacemaker spike, you didn't see any activity. You see a pacemaker spike, we see another one that generates activity. So in this kind of patients, it's not capturing. So there's a problem with the lead. Either the lead has dislodged, the thresholds are not very high, and it's not capturing. Okay. So another differential is crosstalk. So crosstalk means that the atrium, so the ventricle is sensing the atrium. So that's why I said the lead are dislodged. So it means that the ventricular lead can have dislodged and is at the tip of the tricuspid valve. So it will just be sensing atrial activity and it won't pace. Or it's not just sufficient enough to pace the ventricle. Okay? So there's just a problem with the pacemaker, with the lead that just need to. So final summation is that there's failure to capture or failure to pace or capture. So in this patient, so this one, something you see on programming, okay? So anytime you're doing programming and you're seeing a VP, that means that's a paced ventricle. When you see a VS, that's a sensed ventricular activity. Okay? So V sensed ventricular activity, V paced ventricle, V paced ventricle. But there's something that is very significant here. Number one is that we saw a V pace, and on the software, that's why anytime you are doing pacemaker programming, please connect the patient to ECG also, so that you can see the surface ECG and you can see the programming EMG. So in the EMG, it's telling us is V pace, V pace. Now, one important thing in this V pace is that we saw a paced reading, which corresponds to the V pace, VP. We saw an intrinsic activity, which corresponds to a VS. But we saw another VS here, but we're not seeing any surface intrinsic activity. So that means there's a false alarm here. We saw another VS here. Meanwhile, we are seeing a P wave. It is not a ventricular activity. And there's no way you have 2 VS together. It tells you that there's a problem with the electrode. So that means it's not sensing properly, right? So that's oversensing. So when there's oversensing, then there's a problem with the electrode. Okay? So there's no proper sensing in this place. So that's called oversensing, okay? So this patient will need a revisiting of a proper programming. Is either we program it very well that it can sense activity by increasing the sensitivity, because he's seeing P wave and he's sensing it as ventricular activity. That is a wrong sensing. So that means you have to increase the sensitivity of this, increase this, you have to increase the sensitivity so that it's not oversense. So there's where you do that on the programmer. So one of these days we'll go through programming. Okay, so that is what we just discussed, oversensing, and the treatment will be that you should increase the programming. Because if you are sensing what is not there, that means when it's supposed to pace, it will fail to pace. And it fails to pace, the patient can go into asystole because it's sensing what's not there. Okay. Hope I'm still audible. So as I said, our duty is to increase the voltage of sensitivity. Okay, so when you increase the voltage of sensitivity, that means you are not allowing it oversense minor potential. If you increase the voltage of sensitivity, so let me explain a little what we mean by increasing voltage of sensitivity. So when you increase the voltage of sensitivity, that means that it's sensing the voltage maybe around half So let's say this is 5 volts. Each box, right, is 5 volts, millivolts, right, on our surface ECG. So we can increase the sensitivity to 3 millivolts. So at 3 millivolts, it's not going to sense anything below 3 millivolts. So P wave that is around 1 millivolts here, it's not going to sense it. So it's going to only sense any potential that is above 3 millivolts. T wave that is around 2 millivolts is not going to sense it. But if your sensitivity is around 1.5 millivolts, that means that T wave is going to pick it as QRS activity. P wave, it might not pick it because that one's less than 1.5 millivolts. But if your sensing is 1 millivolts, that means that it's going to pick a P wave of 1 millivolts. It will be thinking it's QRS complex. So you increase the voltage of sensitivity, which decreases oversensing. So when we increase the voltage of sensitivity, that means that it will only sense your QRS and it would be blinded to P wave and T wave. I want to be sure if we got that. These are things we just program on the programmer. It's not hard at all. So what I'm saying in essence is that if the sensitivity voltage for this patient is 1 millivolt, so that means that it's going to sense P wave as, remember this is single chamber. He has only single chamber. So if he's seeing P wave activity or T wave activity, he's going to sense it as ventricular activity. So the only way around this is to increase the voltage. The QRS is around 5 volts. So increase the voltage to 3 volts, millivolts. So it will only sense anything above 3 millivolts. It will not sense anything that is below 3 millivolts. So it's going to remove the noise of P wave and T wave. Hope that is clear. Any question? We'll soon round up. Any question, Dr. Eugene?
Prof, we don't have any question in the chat box yet, and no one has unmuted, please.
I just hope it's clear. Okay. So in this patient, we've seen that he has dual chamber pacemaker because we can see the pacing spike in front of suspected P wave and in front of the QRS. So it's dual chamber pacemaker. But with the pacing spike in the atrium, we're not seeing a P wave generated. So there's a problem with the atrial lead. It's not capturing, even though it's pacing, but it's not capturing. But good to know, it's capturing the ventricles. That's why we are seeing a paced ventricular reading, paced ventricle. So this means that it's either the atrial lead that's dislodged and or the threshold for the atrium. There's just a problem with the atrial lead. So that is a failure to capture P wave in this patient. So the same is true for this kind of patient in the sense that, so first things first is that we can see a P wave, a paced QRS, because you can see the pacing spike. Okay. We see a pacing spike here again. We didn't see a QRS. You see a pacing spike here. Huh? Look at the time you saw a QRS, which is actually a ventricular escape reading. Okay. You see a pacing spike here. We didn't see, there's a pacing spike here. meaning that this is also dual chamber because you can see atrial pacing spike. Here we can see another pacing spike for the ventricle, but you're not seeing any QRS. Here we've seen a escape rhythm again because I can't see a pacing spike in front of it. So it just tells you that all the pacing spikes that is coming in is not generating any QRS. So that means you are not capturing the ventricle. Okay? So since you are not capturing the ventricle, that means there's a problem with the ventricular lead, which should be either it has fractured, it has dislodged, it needs to be replaced. Hope that is clear. Do we have any questions? So whatever can happen to the failure to capture, first thing you should think about is the lead. So when there's a problem with failure to capture, the next thing you ask the patient is to go and do an X-ray to see the lead. So if the lead has dislodged, you're going to see it. If the lead has fractured, it might be difficult to see, but it's possible to see if it's very visible. But what we are saying is that the lead has to be replaced, or you go for programming to see is the battery life done, is the battery life gone, and things like that. So they are very dangerous moments, especially if the patient is dependent on the pacemaker. Okay, so we need to. So one of the things we can do is that if the lead is intact, you can increase the threshold. But just know that the moment you increase the pacing output, you'll be draining the battery life faster. Okay? It could be that the myocardium, fibrosis has happened around the myocardium. You are not capturing enough tissue to cause a ventricular activity. So all those things are things you troubleshoot when we are doing programming to see that should we revisit the lead and change the lead or increase the pacing output so that more current will be generated to capture more muscle, more myocardium. Best bet will always be to go and replace the lead because increasing the output means that you will be draining the battery faster. And at the end of the day, when the battery drains off, you still go back and replace the lead. Okay. Okay, so in this kind of patients, there's a problem with sense. So this patient has two chambers being paced. We see the atrial pacing spike, ventricular pacing spike, atrial ventricular. So this is double chamber also. But you will notice that we can see a P wave here. And you are seeing the atrial pacing spike at that place. That means it didn't sense this P wave. Then ventricular activity came in. So if you can see a P wave here, and you are seeing a atrial pacing spike close to a P wave, why? So that means that this atrial lead is not sensing the P wave. So there's a problem with sensing the P wave, okay? But for the ventricular pacing, it's coming, when it's paced, you are generating expected QRS. So there's no problem with the ventricular lead. So there's a problem with the atrial lead, okay? So that is an issue. Okay. I guess we're about to round up. So the issue here is that there is an atrial pacing and there's also a ventricular pacing. I can see the atrial pacing spike, and look at this QRS. I can see a ventricular pacing spike here. This thicker line here is there. I can see another thicker line here that is different from the QRS or the ECG dark line. So you can see all these thicker lines close to this QRS tells you that this patient is pacing on an intrinsic QRS. So you see, this is supposed to be a paced rhythm, but seeing a pacing spike at the middle of QRS tells you that he did not recognize this pacing spike. did not recognize this QRS and is spacing inside the QRS. Okay, so there's a problem with sensing the QRS. So that is a serious problem which has to be addressed. So that is failure to sense. Okay, under sensing the QRS. Okay, so do we have question at this stage? So we've looked at failure to pace, failure to sense for both atrium and ventricle, and failure to capture also. So this is also the same thing. So anytime your pacing spike is not matching with your QRS, then there's a problem. So for example, you are seeing a QRS and you're seeing another pacing spike close to a QRS, and this is a ventricular pace reading because I can see number one pacing spike that generated this QRS, but all through, you are seeing intrinsic and you're seeing pacing spike again. You just saw intrinsic activity and you're seeing the pacing spike immediately after that. Just tells you that it's not sensing there's a failure, there's a problem also with sensing. Okay. All right. So I think we're going to round up here. These are all failure to sense. So I want us to round up here because of time. So one last thing I want to show us is this. When there's a problem with sensing and the pacemaker is just pacing and pacing and pacing, and there's a problem, there's a time you can go and pace on a T wave and you have a R on T and you're going to VF. So anytime there's a problem with sensing or a problem with pacing, that patient should be revisited either for proper programming or they revisit the leads and the battery. Okay, thank you very much. So I'm ending it here.
Thank you very much, Prof, for such a detailed stepwise presentation. We are grateful for this presentation, and may God bless you for taking time off your busy schedule to do this presentation for us. At this point, please, let's ask our questions and seek our clarifications. Then we can close the first part. Prof was asking us questions along, so if we didn't ask, it's likely we don't have questions. But assuming we still have, please let's go ahead and ask our questions so that Prof can clarify. Whilst at that, let's show appreciation to Prof for this wonderful presentation. So, Prof, I must say the presentation was so detailed and stepwise that I think you've really made us understand the basic principles of pacing and diagnosing the challenges that may arise from problems in pace. Thank you very much. We are grateful and may God richly bless you.
Thank you, everyone. God bless everyone.